So a chest tube is usually used to drain fluid, blood, or air from the pleural space in order to re-expand the lung or to restore the negative pressure in the pleural space. So usually what we'll see is either a pneumothorax, which is air, or we'll see a hemothorax, which is like blood. So how it works is that this part of the chest tube, is connected to the patient, and this part over here is connected to the wall suction. So it's very important to differentiate between the two. So here we'll be talking about the dry suction chest drain. So there are a few different chambers in the chest tube. So here on chamber D is what we call a collection chamber. So anything that's being removed from the patient, whether it's blood or fluid, will come in here. So as a nurse, what we want to do is we want to document the consistency, the color, and the amount. So we usually have this all marked up with different dates or times and initialed by the nurse that took the measurements. Here we have an air leak monitor. So as a nurse, we want to make sure that this is filled up to 2 centimeters, which is this line right here. So essentially we don't want to have any air bubbles here. So if there are bubbles, we'll use these numbers to determine how much bubbling or how severe the bubbling is, or how severe the air leakage is. So remember, we don't want to see bubbles in this chamber. So here in section B, we have what's called a water sealed chamber. So what we want to see here is titling. This is what we'll usually see when patients are removing air from the pleural space. So with each inhalation it'll go up, and with each exhalation it'll go down. So if we see that the titling does stop moving up and down, one of two things may have happened. Either the lung has already re-expanded to its full capacity, and in which case we would have to let the provider know so that they can come and reassess, or two is that there's either like a blockage or some sort of kink in the tubing. So it's very important to then assess the tubes. Here we have what's called a suction dial. So one of the good things about a dry suction chest drain is that we have the option to go higher in pressure, suction pressure. Usually this is set at about a -20, but it's very important to check in with your provider to see what suction level he wants it at. Here in section E, we have what's known as a suction monitor bellow. So usually when the chest tube is connected to the wall suction, this will inflate out up to this triangle right here. So this just lets us know that the suction is in fact working. It's important to note that if the patient is not connected to suction and is being and whatever fluid is being extracted from the pleural space is being done by gravity, then we won't see this blow up to the triangle area. So as a nurse, what we want to do aside from the chest tube is we want to monitor our patient's respiratory status, their vital signs, their oxygen saturation, just everything. And we want to also know what to do when things go wrong. So it's very important to monitor all of these chambers. They all play a very important part in the patient's care. The drainage system also needs to be kept below the patient's chest. That's very important. So we can either hang it on the bedside or we can keep it on the floor. They'll usually have a stand for us to put it. And as we mentioned, we want to make sure that it's always secure to the patient and it's free of any types of kinks. On top of that, we want to monitor a patient for their lung sounds and make sure that fluid is being, or what's needing to be drained is actually being drained. We want to also monitor the insertion site, so where the tube is inserted on the chest cavity. Usually what will happen is something called subcutaneous crepitus. So this occurs when carbon dioxide is escaping into the tissues. So upon palpation, it'll kind of feel like this Rice crispy feeling where there's crackling. So it's very important to monitor the patient's insertion site as well. If the chest tube were to ever become dislodged, so it comes out of the patient's chest cavity, we want to make sure to cover the area with a sterile dressing, and we want to tape it on 3 sides in order to allow the air to escape. This actually helps prevent what's known as attention pneumothorax. We want to notify the provider as soon as possible. In order to, if this were to become full and we need to change the drainage system in general, what we need to do is we need to go ahead and clamp this. Make sure this is clamped before actually removing anything, otherwise we're going to have a big mess. So we'll go ahead and remove that out, and we'll want to make sure that we have our drainage system ready to reattach. So we never want to just take it out and then not have it. So then we'll go ahead and reattach it, unclamp it, and go ahead and continue suctioning. If the system were to break, again, we would go ahead and have our new system ready, and then we would just remove the tubing from this side and insert it into a 1-inch bottle of sterile water, and this is going to give us a water seal in the meantime while we go ahead and change the drainage system. It's also important to note that milking, stripping, and clamping are no longer recommended, as it increases pressure and it can cause a tension pneumothorax. So we want to make sure to always follow our hospital's policies.